in here as we go through
Absolutely.
some intros, but my name is Nicholas Franco, and I help coordinate this group with Dr. Chopra, and I am a researcher in the Department of Family Medicine at the University of Washington. And my interest in long COVID kind of comes from working in ID for a number of years, and I am really, I welcome the opportunity to be able to still kind of contribute and stay up to date on the literature, on everything that goes on around long COVID. And so that's me, and I will pass it to Dr. Chopra.
Thank you very much, Nick. And Nick has been instrumental in setting up this group and coordinating this group as well. He has such a lot of experience, and I really appreciate his expertise in not only COVID research and COVID vaccine research, but long COVID as well. Hello, everyone. I'm Anita Chopra. I am an internist and one of the lead physicians at the University of Washington Long COVID Clinic. I'm co-investigator on the AHRQ grant for long COVID at the University of Washington, and I chair this National ACP long COVID group. I am very excited to welcome the newest member of our team, Hamza Hashmi, who is joining us from Pakistan. He's interning with us. And Hamza is an undergrad student who is passionate about biochemistry, about pathophysiology, and the overlap with chronic disease. Hamza, I invite you to please introduce yourself.
Sure. Well, hello, everybody. My name is Hamza. I'm currently an undergrad in my senior year. I'm majoring in chemistry with a concentration in biochemistry and organic chemistry. I'm also hoping to get into UW for my grad school. My interest in long COVID kind of comes from kind of how it affects, diverse populations and how we can kind of bridge the healthcare disparity between these kinds of populations, especially because long COVID has really impacted different South Asian communities very differently. But yeah, that's basically where my interest comes from.
Thank you, Hamza, and welcome to the team. With that, I am honored to introduce Dr. Abby Cheng. Dr. Cheng is our expert today. She is an assistant professor in the Department of Orthopaedic Surgery and Division of Physical Medicine and Rehabilitation at Washington University. Dr. Cheng specializes in long COVID care and is the principal investigator for the AHRQ grant for Washington University. She is co-lead for the PASC collaborative for the American Academy of Physical Medicine and Rehab, and she's working on the long COVID care guideline compendium, which we are all eagerly waiting for. Thank you, Dr. Cheng. Thank you for giving us time today. It's an honor to have you here.
Thank you. Thank you for the invitation, and it's so exciting to be amongst people who are interested in learning about long COVID and taking care of long COVID. I'm happy to learn from you all as well.
Thank you. So I will start off by asking you to talk a little bit about what drew you to long COVID care as a physiatrist and why multidisciplinary care is important in long COVID.
That's an interesting question. I would say the easy answer is, as a physiatrist or a physical medicine and rehab doctor, like we always say our specialty is function. So we don't have an organ system that we specialize in. It's function. It's whole person function-based care. And long COVID care really falls into that bucket. Interestingly, I have subspecialty board certification in sports medicine. I did not expect to be getting into long COVID when I finished my fellowship, but I am part of WashU's Living Well Center, which is a lifestyle medicine-based center that was designed to treat and help patients with chronic musculoskeletal pain. And we were set to open right before the pandemic. And then things were delayed, and we found a new need as well. So we still manage and assist patients who have musculoskeletal pain, but we have a rehabilitative care arm for long COVID care through the Living Well Center, and then partner with the multidisciplinary group at WashU to take care of long COVID. So in that way, I think it's just natural how our institution kind of set up long COVID care. Long COVID affects nearly every organ system and domain essentially in the body. So it does make sense that, you know, we need experts from all sorts of disciplines to help manage patients as best as we can. On the flip side, though, I think one thing that we've had trouble with is in our region, there are a lot of clinicians who don't want to quote unquote own patients with long COVID. They might say, you know, okay, I can take care of the heart, but you know, I don't know anything else about long COVID, see someone else. Or okay, you're short of breath, I will work that up, but then see someone else for long COVID care. And so I think that's why I think, Nick, you were talking about long COVID clinics closing. And I think patients feeling like they have a home is important. So yes, multidisciplinary care, yes, team-based care, but at the same time, we're learning it's very important and kind of hard to find sometimes to find that point person or that point clinician for patients to have for long COVID.
Thank you. That's such an important perspective, and so very important for our primary care physicians also to know how specialists look at this. I will hand it over to Hamza for the next question.
Thank you, Dr. Chopra. So, Dr. Cheng, could you just tell us a little bit about your engagement in the long COVID sphere nationally and just a little overview of what kind of work you're doing at WashU?
Absolutely. It might be a little more interesting if I share a few slides, if I can find them. I would say in brief, in terms of nationally, as Dr. Chopra had mentioned, I'm part of the AAPMNR Long COVID Collaborative. That is, I'm going to share my whole screen, so I apologize if you can see too much. But Zoom is changing, it's formatting on me. So the AAPMNR Long COVID Collaborative really started in 2020 in an effort for people to kind of find like-minded folks who are trying to take care of patients and figure out, you know, what should we do and how should we do it best. This is like the intro slide that AAPMNR shared with me. But for those who aren't familiar, because there are a lot of folks not familiar with physiatry, but really, again, our focus is function. It is a medical specialty, MDs or DOs. And really, we pride ourselves and we try to provide value-based evaluation, diagnosis, and management for all sorts of neuromusculoskeletal conditions. Long COVID very well fits into the wheelhouse of what PMNR does. It's a lot of supportive care. We may not be able to cure the underlying diagnosis, but can we help improve quality of life? So this is a lot of what the AAPMNR Long COVID Collaborative has done so far. It used to be called the PASC Collaborative. We're kind of moving to the Long COVID term instead of PASC because it's more patient-facing and honors the patient involvement in identifying this condition. So there are dozens of institutions and kind of multidisciplinary clinics and providers and clinicians from all sorts of disciplines as part of the Long COVID Collaborative. There have been 10 publications to date. And I think one of the keys that the collaborative has done is develop these consensus guidance statements. So we're not to the point where we have very clear level 1 evidence-based recommendations for all long COVID. There aren't any FDA-approved medicines for long COVID right now. But as best as possible, we're still trying to give clinicians some guidance and, you know, what do we think is the right thing to try and how do we approach these patients to try to do benefit and to not do harm. The part that I'm most excited about is the compendium statement that folks have mentioned already today. So far, most of the guidance statements that have come out are really based on a symptom or an organ system. There's one pediatric statement. But they are very detailed and they're wonderful references. But for a practicing clinician who may not be as familiar with long COVID or may not see long COVID every day, it is not digestible to use in a clinical setting. And so the compendium is really meant to be a clinical resource. It's not something you read once and put away forever. You can there will be tables in there that are easily accessible, referenceable. The vision is that these tables will be linked online through a QR code and you can easily toggle in between and just pull it up as a quick reference. If you're like, you know, which lab should I order or what else should I be thinking on the differential? So that's the point of the compendium. Sneak peek, you guys probably are the first to know, but we got our first round of peer reviews back earlier this week. So I'm very eager to get through those and hopefully get this out in the first quarter of next calendar year is when this should come out. So that's really where I focused with the Long COVID Collaborative. Just to give a little bit of information on what we're doing in St. Louis as part of the WashU AHRQ grant. It's not just a WashU grant, it's really meant to be a St. Louis Long COVID initiative and a partnership across numerous organizations and patient partners and champions. Our WashU BJC health system is certainly a part of it, but we have 4 federal qualified health centers in the region. We have healthcare intermediary organizations, the St. Louis Integrated Health Network being one of our key partners, who also is very trusted among underserved communities and the most vulnerable communities in our region. So we're particularly trying to reach the Black St. Louis community and then the rural Missouri and surrounding Midwest communities, both of which have been historically underserved and long COVID. We suspected, but we found more and more the awareness about long COVID, that it even exists, is much lower in these groups in our region. And then the University of Missouri is also part of our long COVID initiative, and they host their super hub for Project ECHO. And so we're delivering primary care education through ECHOs that the University of Missouri already has established. So just to give an overview of the setup of our clinic at WashU, we have a kind of a long COVID consultation clinic. That's this top left region. That's where patients are intended to start for initial evaluation, make sure nothing is missed, that that's not a different diagnosis, or maybe someone has long COVID and something else. Our clinicians have diagnosed Parkinson's before. People had attributed symptoms just to long COVID. We had some limited social work support, but through our grant, we were able to hire a full-time community health worker. We've instituted in-person and virtual peer support groups. We've had community events. Joshua Roman, the renowned cellist who's living with long COVID, came to our community, and we developed a website as well. That's a patient and clinician facing website, so I can talk more about that later. And then, as I mentioned before, our rehabilitative arm is really integral with the Living Well Center and then WashU PT, OT, and speech therapy as well. With the grant, we were able to add behavioral health care in a timely manner for patients with long COVID, and that's covered by insurance as part of our services. And then we were also able to expand access to PT, OT, and speech therapy. So one of the things we're most proud about is development of our shared medical appointments for long COVID rehab, essentially. So patients in our area, if you have Missouri or Illinois Medicaid, it does not cover PT, OT, or speech therapy for essentially any reason for adults. And so patients who need therapy just essentially couldn't get it. Shared medical appointments are a type of routine office visit that are covered by insurance companies and actually have no copay for Medicaid patients. And so we've developed a 6-session series where we have our lead long COVID OT, PT, and speech specialists kind of give didactic information. There's a check-in. Patients have an opportunity to kind of describe what they're going through, their questions, and they really have a chance to encourage each other, learn from each other, set goals, reassess how they're doing, and kind of go through the traditional therapy process of a goal, work towards it, what's working, what's not, and then iterate from there. And so we have a paper. It just came out online ahead of print Monday, I think, but it should be coming out in a long COVID special issue in the Cardiopulmonary Physical Therapy Journal, CPTJ, in January. So you can look out for that, and then any other issues or any other papers that are coming out in January. I'm excited to see the full issue. I mentioned that we're doing echoes. I think you all may know Dr. Chopra hosted a very successful kind of long COVID seminar that was very well attended by people across the country interested in long COVID. In our region, I think one of the things we keep being struck by is that there are a lot of people in the community and the healthcare world that are not aware of long COVID or don't appreciate value in learning about it. And so we're kind of taking a sneakier approach. We are embedding our echoes into our echo talks into existing echoes. So people who signed up to come to the HIV echo are hearing about infection reactivation and recurrence and how it's related to long COVID. people who are coming to the adult psychiatry echo are hearing about the impact of long COVID on mental health and kind of how to manage that and how to look out for long COVID in their patients. So if you go to showmeecho.org, you can certainly sign up for any of these. I think you're getting a lot more education in this session and these monthly sessions, but we're just trying to spread awareness and awareness about our resources as well in the region. I will stop there for now, but that's kind of a broad overview of what we've been doing.
Thank you so much, Dr. Cheng. And I actually am particularly fascinated and drawn to the echo that you guys are posting. And I think that, and Nick has kindly put the link in the chat, and I think that this would be a very informative thing for our primary care docs, especially on this call. And it would be great if we can attend those echo sessions. I'm going to ask you to talk a little bit about the research going on at WashU in this area and some of the projects that you are part of. And I know you talked about your recent publication, but what are some of the research projects that you are working on in long COVID at WashU?
Sure. So a lot of our research efforts kind of in my immediate group that we're focusing on is related to the AHRQ grant, which is more of a health services delivery grant than a basic science research grant. And so one of the things we're trying to understand is like, where do we need to focus our education and awareness efforts? As part of the ARC grant, we're asked to report about quarterly on, how many patients are being seen with long COVID, where are they being seen? How many visits are they having? And so through those EMR data queries, we're looking into identifying long COVID deserts is what I'm calling it. So if we look at our region and the concentration of providers in our region, there are spots where, there's a high use of the ICD-10 code for long COVID, UO 9.9. And then there are neighborhoods, a couple miles away, and it's not used at all. So how do we identify those areas and then strategically and efficiently spread awareness in those regions, both in the community, so patients can bring things to their doctors and say, hey, I'm having these symptoms, like I saw this flyer, it might be like, could I have long COVID? And then on the flip side to healthcare teams as well. So that's one of the things I'm most excited about that we're trying to do. In general, as part of the ARC grant, we have kind of a mixed methods iterative process where we're co-designing resources and then touching base with stakeholders, patients and clinical teams through interviews and surveys to say, what's working, what's not, what do you need now? We're developing flyers and seeing if that is appropriate for them, what else they need. We developed a website and keep iterating on that as well. Other researchers within the WashU system are involved in a lot of the NIH Recover studies. So studying medications and other therapeutics like Paxlovid, IVIG, structured pacing, cardiopulmonary rehab programs, things like that. There are a few other studies like fluvoxamine for brain fog, stellate ganglion blocks for smell distortion. So there's lots of trials ongoing. By a lot of investigators, put it that way.
So I think that I wanted to make a comment here that it was very fascinating when I went to AHRQ and we exchanged notes there with other grantee sites. What we saw was that the long COVID ICD-10 code was seen in this study that they did at Emory in Atlanta, that the primary care docs, it was seen on audit of their charts in 0.1% of their patients. And the national prevalence of long COVID is 7%. So there's this disparity as to we are not capturing all of these patients. And to Hamza's point, what Hamza said about the inequities, in different populations, especially populations who are more impacted by long COVID, we are not capturing all of them yet. So thank you for emphasizing that. And over to Hamza now for the next question.
Thank you. Dr. Cheng, could you just also take this opportunity to talk about, some other research around the nation about long COVID that you kind of find exciting or that you're anticipating?
Absolutely. And kind of to build off of Dr. Chopra's comment, because I think some of the research that I'm excited about directly addresses this, but some feedback we've gotten from some patients, especially kind of in our inner city Black St. Louis community, we have community health workers going out with flyers and tabling, and someone says, I don't long COVID, I don't have long COVID. Nope, I don't want that diagnosis. Don't say I have that. And some of it is like, I just want to be done with the pandemic. Others is like, people are going to think I'm crazy. My doctor told me that wasn't real. So there are so many barriers to getting people a diagnosis of long COVID. And related to that, I think of long COVID research in like three buckets. The first one is like repurposing existing treatments to try to treat and manage long COVID as quickly as possible. And a lot of the Recover trials right now that are ongoing kind of fall into this bucket. I would say so far there's been a lot of kind of mixed results from what I've seen, and hopefully, and I think some of this will move the needle a bit, but I don't see anything on the near horizon that's curative, like this is going to change the landscape of long COVID care. The second research bucket is kind of the exact opposite. It's development of new treatments that hopefully can target the underlying pathophysiology. And Hamza, someone smarter than me, someone like you, is going to have to figure out how to do that on the basic science side of things. And I think that's absolutely necessary, but I think it's going to take a lot more time. So that third bucket is kind of where I see exciting stuff coming out right now, that really is giving us measurable, quantitative, and to clinicians' minds, like tangible proof that long COVID is real. And when clinicians believe long COVID is real and they can talk about it with patients and they recognize it in patients, then I think patients feel more validated and then they can accept the diagnosis. And really what we care about is that they get the care they need, not so much what label they have. But if we can understand what's going on, it typically is easier to treat. So a couple of studies that I like to talk about with patients and clinicians, especially when clinicians are less familiar with long COVID. One of them was a study, it actually came out in January of this year from Amsterdam, but it's about, it was a study where they took muscle biopsies from people who had post-exertional malaise and long COVID and those who didn't. And they're just measurable basic science changes, like myopathy level changes and mitochondrial changes in the patients who reported and experienced post-exertional malaise compared to those who didn't. So that's just, again, it's not someone patient reporting a 10 out of 10 scale. It's nothing that you can fake, quote unquote. But it's real objective evidence that I think helps people understand a little bit more and maybe believe a little bit more when patients are saying like, I am wiped out, I just can't do anything. So I think that's really helpful for patients. They feel like, yes, this is what's going on with me. And I think some clinicians, it's helped them kind of understand that better as well. Another study that came out more recently in October, I think, this one came out of the UK in Brain, the journal Brain. I thought it was really interesting because they looked at kind of ultra high field MRI scans of the brain. And we're really focusing on symptoms of like fatigue and dyspnea and just that symptom of breathlessness for people who otherwise have normal lung function tests. Everything that we do objectively to test lungs looked fine. But they found microstructural abnormalities in the brainstem, specifically in the brainstem at the sites where the respiratory pathways run. That suggest and lend credence to the fact that, some of these symptoms that people are reporting, it may not be the lungs, but it's still real. There's still something going on. And the more we can understand about what's going on, the closer we are to treating it. And again, I think it adds validation to patients to say like, yes, I feel this and I'm not making it up. And my clinicians hopefully will believe that I'm not making it up as well.
Thank you. And Nick put this the Nature article in the chat. I think it's a great read for everyone. Thank you very much, Nick. And now this brings me to the cream, the cherry on the cake. So let's talk a little bit about the compendium, Dr. Cheng. I know that this is a sneak peek today, and perhaps we are all, we are perhaps going to be the first few people to find out about it. Can you tell us a little bit about the original document first that came out? What was the vision with that? What kind of impact that has made, and now what is the compendium and how will it change things?
Absolutely. So as I mentioned a little bit before, there are multiple statements, I think 8 so far, that have come out with consensus guidance, but they are all, again, very detailed. I think a lot of the multidisciplinary, like long COVID specialty clinics have used them and cited them and referenced them, and it's been helpful for those folks. I think, again, as we're focusing on educating primary care, and as Nick said, long COVID clinics are closing. I think the government thinks and assumes and is hoping that a lot of long COVID care will shift towards primary care just because of the sheer numbers of people with long COVID care. We need a resource for primary care, people who have 15 minutes or less to see a patient, evaluate them, manage, kind of start the process. So that's really where this statement is very different than the others. There are pieces of all the other statements in this one. There are updates. So, some of these statements, the original ones were written 2 years ago, 2 or 3 years ago. So some things have changed. And so it is an update, but more than anything, it's more of a succinct, basic, like, what do we do to start the workup and to be approachable for a more generalist clinician, a frontline primary care doc, physiatrist, someone who manages a lot of things, and long COVID is not the only thing they do, and they don't have an hour long to take care of patients for long COVID. If you're interested, I can, again, start with a sneak peek. If I am going too fast and you want more detail, let me know, or if I'm going too detailed and you want it faster, I can do that as well. But I kind of want to give an idea of like how things are set up so that hopefully when this does come out in a few months, if you're interested in looking for it, you kind of know where to go for what you're looking for. The first table is really split up into the different statements that are already published. So physical fatigue was its own guidance statement. Breathing and respiratory was its own guidance statement. So to help orient folks from those statements into this one, we have a first table that kind of groups, what symptoms are we talking about in each of these categories? And then importantly too, what are differential diagnoses to consider? Because we do want people to get diagnosed with long COVID if they have it, but we also see the flip side problem where some people are getting diagnosed with long COVID and everything else after that, or maybe they don't even have long COVID and everything is being attributed to long COVID when they have other treatable conditions. So we want to make sure that clinicians are still thinking about the differential. This is an example of one of the rows in that table 1. So physical fatigue, we're really focusing on severe exhaustion, also differentiating between kind of fatigue and exhaustion all day long, every day versus post-exertional malaise or post-exertional symptom exacerbation. And then we include a differential diagnosis of some of the more common disorders and or some of the things that are more likely to be missed. On these slides, the QR codes just link to that original statement. In the online version of the compendium, it will easily link back to those original statements as well. And then just one more example from table 1. This is the content in the autonomic symptoms row. So some of this is very intuitive, autonomic symptoms related to lightheadedness, syncopal episodes. But we also wanted to highlight that sometimes people have dysautonomia and they may not say, I get dizzy when I stand up. They may say that, I can't, my temperature tolerance is just changed and not right. I might have digestion changes, perspiration changes. So really just helping clinicians key into these other manifestations. And then we really dive kind of into the assessment, and we start with holistic assessment and holistic management, and then we get more detailed into each of the individual symptoms. So the idea is let's figure out kind of big picture what's going on, and then if you need to reference a more detailed table, you can, but let's try to get the nuts and bolts into about 2 tables. So the way we broke down assessment in this table is with the kind of the baseline knowledge that primary care docs and physiatrists, clinicians know how to do an H&P. So we're just trying to supplement and give people like little tips of like, all right, what am I looking for in my normal H&P? First of all, what are the symptoms? We list kind of the most common symptoms for people to make sure they're asking about or thinking about. If someone comes in and says, in the last couple of months, I've had this crazy fatigue. I can't think straight. I can't do any sort of activity without getting tired and just being wiped out. That should just key you into long COVID. We also ask about timelines of symptoms, especially because the current NASM definition of long COVID really requires 3 months of symptoms to meet that definition. And we highlight, yes, this theoretically, this happened after a COVID infection, but we don't always know when someone has a COVID infection. So we wanted to acknowledge that, we may not have proof that someone had a COVID infection, but they could still have long COVID. And then we get into elements that are related to diagnosis, but also starting to think through management. So what is making things worse physically, cognitively, socially, emotionally? Sometimes vaccines and boosters make symptoms better. Sometimes they make them worse for a while, but let's think through that. And then this is kind of where our physiatry hat comes on even more. We think about function. And again, this is related to thinking through management, but it's also starting to think through that disability and paperwork process if that's relevant for a patient. So can they do their ADLs, IADLs, work in school, and like what do they do for work, and what specifically related to work is tough for them if it is tough for them. Still want to think about a differential diagnosis, something patients might have had pre-existing conditions that really kind of unmasked when they developed COVID infection and long COVID, or they could have developed something new. We don't want to miss those things. And then in terms of the physical exam, it's really mostly symptom specific. So, if somebody has cardiopulmonary symptoms, you do a cardiopulmonary exam. Clinicians know how to do that. We weren't going to go through that in this statement. You can reference the cardiac and pulmonary statements if you want a more detailed description. The one test we wanted to highlight was just a 10-minute stand test because autonomic dysfunction is so often missed. So we do encourage that. The next table is for labs and procedures. So again, this could be a really good reference guide for folks. I will say of the consensus that we got, this was probably one of the tables that took the longest time to get consensus. I can't say there's a clear right or wrong answer, but we really wanted to be mindful of, this is for a generalist, and this is, we're not trying to do the $1 million workup on every patient. We want to be mindful of the tests we order, but for a holistic assessment, their basic labs we should check. And then for each specific symptom or type of organ system dysfunction, we have some other labs to consider based on the patient and the situation, but to just give ideas of like, hey, am I thinking through, what I might need to be checking? So again, the labs and procedures table has a row for each one of these specific symptoms. And then we get into management. The first step of management is validation. So these quotes are kind of built into the table just to give clinicians a quick and easy idea of like, what can I say to patients and how do I say it so that they feel heard, they know they are heard, and then we can offer hope and also realistic updates on, where is the state of the field right now. So I can come back to this. I can share these slides, but we just have a few different things we can say depending on what patients are looking for. The second mainstay of holistic management is managing symptom triggers. So pacing, a key, and then workplace and school accommodations. I know you guys really want to hear about disability stuff, so we'll get back to that. The one figure we have in the compendium is about return to physical activity. And specifically, this is not just related to exercise. We are not encouraging exercise for patients who can't even shower without fatigue. This is really kind of to meet patients where they're at. I think a few things to highlight is the top left, kind of where people should kind of start looking is decrease intensity level. If someone cannot tolerate what they're already doing, let's start by decreasing their intensity until they can do things without triggering PEM or PESE. And then we can gradually work towards increasing intensity as tolerated. As a physical activity is increased, you first increase the number of activity bouts before increasing the duration. So if they can tolerate 5 minutes, let's do 5 minutes twice a day. Let's not do 10 minutes all at once. And a lot of folks contributed to this figure, including physical therapists who are very experienced taking care of these patients. So lots of credit goes to lots of folks for this. And then we help patients and clinicians kind of walk through activity intensity levels. Some of this is very like clinician focused and clinician geared, talking about ratings of perceived exertion and heart rate max. And some patients love using their activity trackers and the heart rate monitor. So we have guidance there. There are other patients who that's not feasible for them, or that's not what they're looking for. So we also kind of give more, if you need to talk about this with a patient in 5 minutes or less, low intensity activity, you can walk, you can talk or sing. moderate intensity, you can talk, but you can't sing. So kind of varying levels of detail to use to talk with patients, or to talk with, for clinicians to talk to patients and describe the general approach. The contraindications are fairly self-explanatory, but if an activity level is triggering post-exertional malaise, that's too much right now. And then if there are cardiac concerns, we recommend cardiology clearance before proceeding. Other holistic management principles are very, very familiar with primary care. So manage kind of general lifestyle principles that they're really, really important. I think one of the things Joshua Roman said when he came to our community that I think was really helpful and potentially good for other patients to hear too is he's like, I really need to get my sleep. I really need to focus on my nutrition. He said, this doesn't cure me. It doesn't make a night and day difference, but it makes a 5% difference. And all of these things I'm doing make like a 3 to 5% difference, and it adds up. So for patients who are feeling discouraged, again, it's a multi-pronged approach, but it does make a difference. We have a section on optimizing medications as well. Sometimes that's prescribing and sometimes that's deprescribing. And then kind of general guidance that primary care is familiar about for follow-ups and collaborative care. If you're making medication changes, if someone is, not able to work, like we need to make sure we can follow up and that they're doing okay. If they have a plan and have good kind of self-management skills at that point, follow-up as needed is fine. Table 5 could be a good reference table as well that folks might want to come back to. So it's a medication table. Again, it's meant to be for a generalist. We kind of break symptoms up a bit by type of symptom, but there are a lot of medications that overlap in terms of making multiple symptoms potentially better or making some symptoms better and some worse. So in the table, we have general the medication names and general dosing that's been used in long COVID, and then indications and also side effects and things to think about. So someone who has brain fog might benefit from methylphenidate, but it might make their post-exertional malaise worse if they overdo it while they're on the methylphenidate. So we need to think about that and counsel and consider if that's the right medication for them. So again, most of these medications you probably have heard of and use regularly and feel comfortable with. If there are some that you don't, that's what this table is for. But just to give a good starting point, there are a lot more medications in the previously published statements, but we wanted to get a more succinct list in one spot. And then I think more of the exciting part that Dr. Chopra asked for, thinking about accommodations and disability. I have another slide later, but this is one of the tables in the compendium statement of, what is the clinician's role? Through the ARC grant, we had a talk by people from Social Security and some patients who are also social workers and have been through the disability application experience from multiple sides of it. And it was just so clear how crucial it is that clinicians support patients through the process because their livelihood, their financial well-being depends on it. And everything is held up if they can't get the support they need from the healthcare system. I think a few key things to think about are, again, what does the person do for their job? What can they do now? And how can we make it better? How can we try to keep them in their job? I think that's a lot easier for kind of desk work. You can do remote work, flexible work schedules. That's great. It tends to be harder for patients who are working more manual labor jobs. Some of the things we highlight in terms of appropriate accommodations there are gradually returning to work. Like let's work, 4 hours a day. Because, if you're in a factory, you can't, work remotely and sit down necessarily. Like let's have a shorter time. Let's do every other day. And you kind of work up from there. Tends to be a more successful accommodation for more manual labor jobs. And then in addition, establish expectations with the patient. None of us know the course of long COVID for a given patient, but as much as we can, we want to establish realistic expectations. Using the ICD-10 code for long COVID, UO 9.9 can be really helpful. And then also use any other codes that are related to the specific symptoms that patients have can be helpful as well. In terms of SSA disability, what we're told they're looking for is really, what is the patient's job and what can they not do and why can they not do it? If there are any objective tests that can show pathology, whether it's a VQ scan or a CT or pulmonary function tests or neuropsych testing, anything that we can show objective changes is really helpful. Mental health can be in documentation from that standpoint, or even kind of serial patient-reported measures on a PHQ-9 or a GAD-7 depression or anxiety measure can be more helpful than not. But documenting the time course and the severity of symptoms can be really helpful. And then from there, we have symptom-specific tables. I'll go through these more quickly. If you want me to slow down, I can. But we try to hit highlights for, again, if someone has physical fatigue, what do we do? 4 Ps, 3 Ds. So Ps are pacing, planning, prioritizing, positioning. Ds are delete, defer, delegate. Again, in terms of medication management, it's not always about adding meds. Some of it is weaning meds that might make things worse. Patients may have tolerated somewhat sedating meds before long COVID, and now they don't. From a pulmonary standpoint, one of the big questions, is this a pulmonary issue causing breathing discomfort, or is it non-pulmonary? Is it musculoskeletal? Is it autonomic? What else is going on? And then from there, if it's pulmonary, treat the pulmonary issue the way we would otherwise treat pulmonary symptoms. One key thing is if someone has breathing discomfort but no objectively impaired lung function, we caution away from things like inhaled corticosteroids and other medications like that. From a cardiovascular standpoint, very similarly, is this cardiac, or is it something like chest wall pain, something that's not specifically cardiac in nature? And then really the big key of this is the return to activity figure. Also think about the cardioactive meds. Are these helpful for the patient? Are they making some other symptoms worse, like our beta blockers worsening fatigue? We're not saying stop them, but we're saying think carefully and as needed, discuss with cardiology. From an autonomic dysfunction standpoint, a lot of this is daily fluid and salt intake. Some of the things I really like too are ideas for exercise. Even if someone is having symptoms of dysautonomia, you can lay down and you can do a recumbent bike. If someone is safe, or depending on their situation, swimming is a recumbent type of exercise that can help patients just start to work on activity. And then there's also the recommendation from some of our autonomic specialists in the group to assess for hypermobility syndrome. The prevalence of symptomatic hypermobility seems to have gone up after COVID infection. And again, there are more specific guidance for people with hypermobility in terms of, you don't really want to work on stretching because you don't need to stretch. We need more stability than mobility for hypermobility. So think about that in patients. These pictures are counter pressure maneuvers that if someone is feeling autonomic symptoms, they can help in the moment. So if you're standing and you have to stand, cross your legs. If you can squat, that's going to help. If you can squeeze your fists against each other, that's going to help as well. From a cognitive standpoint, a lot of cognitive management is treating the cognitive symptoms. If somebody is working or needs to get back to work, or see if they can get back to work, consider vocational rehab, OT, speech therapy, neuropsych testing. And then also, if you're not sure, it's always helpful to obtain collateral history from a family member or a trusted friend, someone who knows the patient before and after the symptom onset. From a mental health standpoint, one of the keys is to really understand, is this a mental health symptom, or is this another long COVID symptom that is sort of manifesting or disguising itself as a mental health symptom? So if you take a PHQ-9 and you ask someone, are they interested in the things they used to be interested in, and they say no, that doesn't necessarily mean you diagnose them with clinical depression. Is it really that they have no interest in it, or are they so exhausted they say, I don't want to go to my kid's soccer game because I can't tolerate it? Similarly, if someone is having palpitations, is it panic disorder? Is it anxiety? Or is it true, tachycardia and dysautonomia causing episodic heart rate changes? So be careful with that, but also know that long COVID pathophysiologically can cause mental health symptoms, new or worsening. And then also everything patients are going through with long COVID can also worsen mental health symptoms too. And I think this is the last one. Neurologic symptoms, again, a lot of it is treating the neurologic symptom the way we would otherwise treat it. It's very much supportive care. But just realize that there's so many symptoms that are often thought of as functional or vague, but can very much be related to the neurologic symptoms. So, pain, neuropathic pain, small fiber neuropathy type pain, headaches, sleep changes. Sleep is a really big one that people are experiencing, but just acknowledging and recognizing that these are neurologic changes after long COVID that we should consider in that lens. Okay, I'll stop there, but happy to answer any specific questions.
This is just so fascinating. First of all, thank you for the sneak peek. I just cannot believe it that we got this first peek into the compendium. But what I loved from what you showed us is, number one, just the ease for a primary care physician to look at the phenotypes and just click on what they want. And I also especially loved the tables. I think the activity table is just wonderful. It's very easy for a primary care physician to look at and see where the patient is. Pacing has been explained very beautifully. I also love the dysautonomia, and I learned a lot from the MCAS. You've painted a very good picture of MCAS. It's very easy. The medications, even the refurbished medications, are very easy to navigate. So thank you so much for making this compendium such an easy thing for us to understand and to use and implement in our primary care clinic. I'm sure all of us have enjoyed these slides, and we cannot wait for the compendium to come out officially. Over to Hamza for the next question. And meanwhile, folks, please feel free to put questions about the compendium in the chat if you have any. But Hamza, please go ahead.
Thank you. So, as Dr. Chopra mentioned earlier, Dr. Cheng, a lot of our audience members are, primary care doctors. So, what are some of the resources available to them for long COVID care?
Absolutely. I'm going to share my screen one more time. So I'll go through a resource that we're developing at WashU, but you can screenshot it if you want the information. And we're happy to disseminate. We're still finalizing, which is partly why it's not widely available yet. But from the ARC learning community and the talks we've heard there, and then from some of our therapists and other disability specialists in our region, we've put together this flyer that we really intend to be clinician facing and very much primary care or physiatry facing, about, what are tips, like how do I get through this disability process? And in the midst of my very busy day and my dozens of other patients. So I think a few keys to think through are that what we were told from SSA and from patients who have gone through the process, a good clinic note will go a really, really long way. You don't necessarily need to write an extra letter on behalf of the patient. If you write your good clinic note, it should have everything they really need. If the patient does need extra paperwork filled out, maybe for FMLA or for their job or for other things, we recommend scheduling a clinic visit for two reasons. One, that way you're not doing it after hours. And then two, there are a lot of questions that clinicians just say, I don't know how to answer this. I don't know what you can lift. I don't know what you need to be able to do. So if you do it together, it kind of protects your time, and it is probably more accurate if you do it that way. If a patient has been seeing a physical, occupational, or speech therapist, if they feel comfortable, it can be a really good resource to work with them and ask them to help fill out some of the sections that are relevant to the things that they're treating and helping the patient with. And even if they don't fill it on the form, if they can essentially give you a cheat sheet and give you the answer of what is this patient lifting in therapy? What is this patient able to do? How long are they able to stand? That would be more objective and helpful to you. So if they can't do that specifically for the form, you could still refer to their notes, and a lot of that information might be in their notes. And then in terms of what to put in your note, a lot of this we talked about or kind of brushed over before, but list all the long COVID symptoms. So sometimes it's not just one symptom, it's the combination of all the symptoms that someone is experiencing that really contributes to disability. So talk about all the symptoms, the severity, and the chronicity. For things like SSA, the condition must have lasted or be expected to last 12 or more months. So if a lot of times, the forms are asking about prognosis and expected time course. If someone is applying for Social Security and you think they really qualify and need this, you don't have to make the determination of qualification, but if you say, yes, they are disabled and they are not able to work, if it is reasonable to say this is going to last 12 or more months or already has, I would just flat out say it. On the flip side, if this is for a work policy, our therapists have counseled that, it's probably better to underestimate how long you think this is going to be affecting them. As needed, you can reassess, but you don't want them to lose their job because you say they're going to be out for a year and their employer says that's not feasible. So just a couple of things to think about. Again, including your physical exam and then any test results that can remotely show objective measurable changes. The 10-minute stand test, again, may be a really good one to show this more so than some of the other tests that we often run that are normal for patients with long COVID. And then the key thing to ask in your history is, again, what does the patient do for a living? And what are they not able to do because of their symptoms and why? So, this could just be things like sitting or standing. This could be cognitive issues related to brain fog. Also just kind of social, emotional energy, like interacting with others, being in a loud environment, dealing with all of that stress. So the more you can understand what their impairments are, the more you can document that. So what are they not able to do? The other keys are, again, you do not have to fill out disability forms from lawyers, so don't feel burdened by that. Instead, focus your time on a good note and then any forms that were specifically brought by the patient, not for the lawyer themselves. You also do not make the determination of disability or payment, so don't feel that pressure either. And as I mentioned, you don't have to write a separate letter for your professional opinion. Another thing we heard about through the ARC grant was that Social Security benefits actually have programs to help people get back to work and to do it on kind of a trial basis so they don't lose all their benefits by trying to ease back into work. And so getting patients that assistance, and if they qualify and they really need these services, they may get back to work faster. So consider that. And then askjan.org is a nice website that there's a lot on it, but basically it helps match patients' jobs with potential accommodations that might be helpful. So you can explore and peruse that website as well. And then the other resource I'll mention, we made this for our region. It's a website called longcovid-stl.org. This QR code will take you there. Full disclosure, a recent formatting update was launched, and we're still revising some of the content and updating that. So I was told in the next week it will be done. There's a patient and clinician facing section, but what I really want to highlight for this case and for patients section, there's community resources. And in that there's self-management tools, and there's a section on disability and peer guides of how to go through the disability process and other things that might be helpful. So you can ignore the things that are St. Louis and Missouri based, but there's a lot of other more general information that could be helpful for patients here.
Thank you. And over to Hamza.
Thank you. That was very interesting stuff. Let's open up the audience questions. Dr. Fernando, I think you've raised your hand. Do you have a question?
Yes, thank you very much, Dr. Kent. Excellent presentation, and thank you, Dr. Chopra, for putting this together. I think that I'm almost like a question, like a comment. I think that this is very comprehensive. One of the things that I'm worried, and I don't know if you share this worry, if our message is that we're creating these tools so the primary care provider can do this in 15 minutes or 20 minutes, or we should really, present this as a tool that will help you, period. But again, the degree of comprehension in that these visits are requiring today, I think that if we create tools with the hope that we're going to satisfy this 15-minute, 20-minute, time that we give to providers, it may be perhaps a route where we create more frustration and we create burnout into whoever would like to do this in the future. Again, understanding that perhaps we cannot change this, but I don't know if our message, and that this is the question, do you think that our message should be we creating these tools in order to have some unify approach, but not really with the goal of like for you to do this in 10 minutes, which is like, as we said before, 10 minutes is some of the testing, but thank you.
Yeah, thank you for raising that point. And I will clarify, nowhere in the compendium do we say this should be feasible in 10 or 15 minutes. This is, I would say, more in response to the natural shift that has been happening and pressures that have been placed externally on the primary care community saying, hey, you got to learn this, you got to do this. So I would say most of the content in the compendium, if clinicians can go through and say, okay, I understand the basics, I can just review the tables. And then if I have a patient coming in and I need to reference, I can go quickly to the table again. That's really the purpose of it. It can also be used in multidisciplinary long COVID clinics as well. There was a lot of debate and just angst about, again, how thorough to be and how kind of generic to be. We have had much more thorough content in the past, and this is very much cut down, but I agree, it's still a lot. So it's meant to be a tool. It is not meant to assume or suggest that this can be all done in 15 minutes in a single visit. Maybe this is, over several visits, or maybe you can focus on one symptom when a patient is there, but we don't say that in the compendium at all.
Thank you.
I'm looking in the chat. There's a question about nuanced testing, like labs such as IL-6, TNF alpha, GI markers, co-infections like HHV6, EBV. We did, and probiotics. So we did mention some of those labs in the footnote of the full lab table. What we tried to focus on in the actual table was what would change management? And a lot of it is ruling out other things. So of the data that's been out so far, the group felt like there's nothing that's diagnostic of long COVID. And so you may have an elevated or abnormal TNF alpha or IL-6, but A, is it an expensive test? B, is it going to change what you do? And if not, then it's not a frontline management tool at this time necessarily. Similarly for HHV6, EBV, again, if it might change management, or for particular patients, I really don't know if this is long COVID, but they have a positive EBV titer, maybe that sways me more towards it. It's not wrong. It's not in the frontline, everybody should get this sort of table. We mentioned a lot of probiotics and supplements that have been used, and for some patients, they've reported a lot of success. Some of them, again, especially with like lack of regulation for a lot of supplements, we said, be cautious, be mindful, but we list things that have been in the literature that some patients have reported benefit from.
Great, thank you. I'm a naturopathic physician out here in Seattle, and I found the way you gave your presentation, it's very holistic. That's how I practice, and so I much appreciated even the mindfulness around the cost of these tests and those type of things, as well as I'm really curious about, did you come across anything regarding, like, I guess what we're kind of thinking about when we treat these patients holistically is that we're trying to support all around them in all these other categories. But my question would be more is it in theory that then we're trying to let the immune system just kind of re-regulate itself, in the thought that, by lowering stress, better sleep, all of these things, that we just wait? Because what I'm finding in some individuals is they either can't wait long enough, i.e. they get COVID again, or they get a booster, or then they get sick with another kind of cold. It reactivates their immune system in some way, shape, or form, and then they get a retriggering of their inflammatory markers, let's say, or they get retriggered with EBV, and then they backslide maybe. And hopefully they've learned enough skills, right, to get out of the post-exertional malaise and get out of the cognitive component. But I just am curious, my question would be then this thought process around the persistent antigen theory, and can we treat the root cause, so to speak, if the body's immune system is so depleted, like just immune exhausted, that it can't, then you get into these mast cell situations. So that's kind of my question is, other than just waiting, with all the supportive therapies, is there any thoughts around what brings people to the next step to make them more immune resilient or more immune tolerant to, these type of things?
Yeah, I would say my short answer is that is above my pay grade, and Hamza is going to need to cure this and figure this out on a basic science level. It's not in the compendium, and really just because the evidence isn't there yet. The compendium, I'd say, is a very holistic physiatry lens of like, let's support the patient even when we don't have the curative answer. Like, what can we do to stop all of this from happening? I would love to stop it. I am not aware of how to do that yet, and the evidence and the trials are not there yet at all. I do think that's where a lot of the basic science and the recover trials are hoping to get to. We just don't have it yet. But if you figure it out, share it.
I'm working on it. Thanks.
I think in the interest of time, we are on the hour, so we will wrap up now. Thank you so much, Dr. Cheng, for your time, for the sneak peek into the compendium, for making it so simple and easy for everyone to understand, and for all your hard work in putting this compendium together. We really appreciate you coming here today and talking about your work, the research and compendium. Thank you very, very much.
Thank you. It really was an honor. This is a very inspiring group, so thank you for your time.
Thank you so much. Thank you, Hamza, for joining us today and for the enthusiasm you bring to the group. And we cannot wait to see you, see what you do in the coming years. Thank you, Nick, for putting this together, for doing such a great job of putting together the questions and inviting our expert guests. So thank you so very much. All right, everyone. See you next month for another session.
Thanks, everyone.
Thank you, Dr. Cheng.